Yeah, thank you very much. I have two short cases showing a certain technique of the treatment of extremely calcified femoral popliteal lesions, which was invented in Leipzig and frequently done here as well, and it's called crack and pave. At first, what kind of interventional options do we have for the treatment of severely calcified femoral popliteal lesions besides semi-compliant balloons? We could at first do alternative balloon technologies like litoplasty, cutting and scoring balloons, maybe high-pressure non-compliant balloons. We can also do atherectomy, or go around the lesion with an interventional bypass like PQ bypass. Of course, we can do stenting, maybe the stent implantation of the standard nitinol self-expanding stents is not the most feasible option because, as we know from a study here in Leipzig from 2010, where we treated 120 SFA CTOs with nitinol stents, we had a quite high rate of residual stenosis, over 30%, and then a poor primary patency outcome here. So that's why I want to show you my first case. A 70-year-old man with failure of standard nitinol stent, as you can see here in the pictures, having an occlusion of the distal SFA over the whole popliteal segment due to this severely compression from calcium, especially in the popliteal segments. What we have done here with this case was trying to get through the lesion by antegrade crossover access, and as you can see here, it was not possible to go through the lesion, so we made a retrograde puncture over the proximal part of the tibial anterior, and after a cart maneuver we could manage the guide wire passage through, and so we dilated this area with a 6 mm balloon. And here's the control angiography, where you can already see recanalized vessel, but with massive recoil due to the calcification and as well a perforation in the distal part of the SFA. So here in this case, for cracking and paving, which we would do in this patient, we implanted a 7 mm Viabahn and post-dilated aggressively with a 7 mm high-pressure conquest balloon up to 35 atmospheres in order to, on the one hand, crack the calcium around the Viabahn, and on the other hand, prepare the Viabahn for implanting supera stent, which would be necessary if you see the picture on the right side, where there's still a quite narrow area in the popliteal segment. So here we implanted a 6.5 mm Viabahn, supera stent into the Viabahn, and the patient was fine then, and we saw him again 6 months after that with a good result. In the X-rays you could see nearly no compression of the stent and a really good runoff over the SFA and popliteal, and he still doesn't have any problems in his walking distance. So the second case is a 72-year-old male patient with severe claudication on his left calf, Rutherford class 3, with a walking capacity of 100 meters and a poor ABI of 0.6. Here you can see the angiography with a severely calcified CTO lesion reaching down to the P1 segment. Here it's a little slow, but a good outflow down to the foot via the anterior tibial. What we have done in this case was also trying to get a guide wire through the lesion via antegrade access, which was not possible, so we punctured the proximal tibial anterior around about 15 centimeter distal to the patella, where it's large enough to take a 4 French sheath in. And afterwards we managed to get through the lesion with a 0.35 stiff angled glide wire and a Judkins Wright 4 French catheter from below. In order to manage the snaring maneuver, we pre-dilated with a 5 millimeter balloon here in this severe calcification. You can see the snaring maneuver. So, and then we had to treat the lesion, of course, as you can see here, by using a 6 and 7 millimeter semi-compliant balloon. You can see it's not fully opening, so we had to do it more aggressively with a 7 millimeter conquest balloon up to 50 atmospheres. And after using several of them, rupturing, you could see the result here, where you can see massive dissection and recoil, which you cannot leave like this. So in this case, we also did the crack and pave technique. Here you can see a tumescence anesthesia, because we want to avoid the patient having severe pain doing the cracking maneuver of the calcium. Therefore, we use a 9 centimeter 21 gauge needle and applicating 1% of lidocaine around the vessel. Here in this picture, you can see the implantation of the 7 millimeter Viabahn through the calcium as well, and aggressively dilating with a 7 millimeter conquest balloon. In the next pictures, you can see here the calcium. Sorry. Doesn't. You can see the crack of the calcium in this picture. It's always jumping, sorry. Yeah, this is necessary just to give space to the Viabahn to implant gently a 6.5 Supera stent inside to stabilize the whole Viabahn and to avoid restenosis in this case. And here was the result. We are quite confident with it, and still good outflow without any distal embolization as well. So we also have, of course, some data for the crack and pave technique. We included in a study in our Leipzig registry 67 patients, 54 of them men, with a mean lesion length of 27 centimeters, mainly task D lesions, and 92% total occlusions. The maximum balloon diameter and Viabahn diameter was in common 6 and 7 millimeters, and we used 5.5 millimeter Supera as well in the half 6.5 millimeter Supera for the paving. The procedural success here in this case was 100%, and technical success 98.5%, because of one case having residual stenosis of 30%. And we have also some good patency rates after 12 and 24 months, from primary patency of nearly 80% and a secondary patency of around about 90%. So in summary, the crack and pave technique we use in Leipzig quite often appears to be a practical and valuable way to successfully treat extremely calcified femoral popliteal lesions, and therefore has become the method of choice in our hospital to recanalize heavily calcified lesions. And I think there are several more data coming soon. Thank you.